it. So, fortunately or unfortunately, next lecture is also not helpful for your exam in a couple of weeks, but it's more like an investment for the future in 2-3 years. I'm gonna show you 70 slides in next 2 hours, but only one slide is important. The rest is, once again, just for future investments. So the agenda is that the first 1 hour until 11 o'clock, we're gonna discuss hormonal regulation of the kidney function by mechanisms other than RAS. I know you guys know a lot about RAS. That's our favorite. But in the body, in reality, there are other mechanisms available in the body too. So we're going to cover that, which most likely not going to be asked on the exam. The second part is that the heart-kidney association, including the effects of MI on the kidney. So this kind of table you can find in a renal physiology textbook. So there are multiple hormonal systems available to regulate GFR and renal blood flow. Sympathetic nervous system and then angiotensin, you know a lot about it, so I'm not going to talk about this today. But there are more than that: endothelin, prostaglandins, bradykinin, kinin, and then natriuretic peptides. Those are also well-known regulators for GFR and then renal blood flow. But truth is, in reality, angiotensin 2 is overemphasized last couple of decades, in my opinion, for two reasons. Number one, the system is biochemically well characterized. The rest, prostaglandin well characterized, but not in the kidney. So the rest, those molecules, the system are not well characterized yet, under a lot of research and investigation. Number two, the ACE inhibitors, or ARBs, were so powerful and then generated a bunch of evidence-based medicine. So clinically, this ACE inhibitor changed the world, and that's why, and also pharmaceutical companies wanted to emphasize how important ACE RAS system. So that's why a little bit, in my opinion, angiotensin 2 is overemphasized. But the reason why I said this is a future investment is that by the time you guys become a physician 2-3 years from now, I expect a lot of drugs using those systems will be available. And actually some are already available, but not as established as ACE inhibitors or ARBs, but they are improving drugs right now to use those systems. That's why I wanted you to know what's going on in this system for the future investments, because you start working in a hospital, a new drug comes out using, let's say, natriuretic peptide, and then you heard about it, and then you don't know what's the mechanism for this drug, and that's not a good idea. So that's why I want to introduce you to the importance of other mechanisms. It's going to be a little bit boring because I'm talking about a bunch of molecular biology things, but be patient. But first, I'm going to start with endothelin. The endothelin is famous for the most potent vasoconstrictor. Endothelin interacts with almost every cell types in the kidney. Endothelin also modulates extrarenal system, including vasculature, the heart, nervous system, and then adrenal gland. So endothelin have multiple functions as much as or even more in the future than RAS. Regulation of function. Endothelin, there are several isoforms, ET1, ET2, ET3, but the most well-characterized ET is ET1. So I'm going to talk about ET1 mainly today. There are two different types of receptors, ETA and ETB. And ET1 acts primarily in autocrine and paracrine, so there is no plasma ET. Normally, it's not, if you want to measure ET levels in the plasma, you cannot measure it, it's too low. So the system is just local. It's autocrine or paracrine. So just a simple, from mRNA, it's generated. The precursor type is called big endothelin 1. And the funny thing is that, like ACE is an angiotensin converting enzyme, right? There is the enzyme called ECE, endothelin converting enzyme. That converts from big endothelin to the mature endothelin 1. So it's very similar to like ACE converts angiotensin, the same thing. Why I'm talking about this? Because if you look at the kidney, ET receptors are expressed everywhere in the kidney, nephrons. Starting from glomerulus, mesangial cells, afferent and efferent arteries, even capillaries, and then all the way to the nephron. Endothelin receptors are expressed everywhere. Okay, so let's quickly see how it works. The first thing is each one is, like I said, vasoconstrictor. So this one actually, it's good to remember this function because it's actually clinically used in pulmonary hypertension. Which I'm going to talk about this later, but this is vasculature. So this is endothelium, and this is smooth muscle cells. There's absolutely no need to, remember those. What I want to say is that endothelin is secreted from the endothelial cells and then binds to the receptors on the surface of smooth muscle cells, and then let's say binds to ETA, and then a lot of things going on, but that doesn't matter. At the end, it causes a contraction. So ET1 mediates renal vasoconstriction through ET receptor signaling. One thing, I think I showed you this before, but one thing, good thing to remember is the mesangial cells. The origin, mesangial cells is phagocyte. It eats a lot of junk in the glomerulus. But this is originally from smooth muscle cell, so it can contract. Then if it contracts, it changes the surface area of the capillaries. So that's why it can change the GFR. That's what I talked about it 2 weeks ago. Because of this mesangial cells is the smooth muscle cell origin, endothelin 1 also works on mesangial cells. Mesangial cell itself produce endothelin 1 because there is a gene inside, and then it's released, and then because of autocrine, it binds to ETA receptor and ETB receptor. And then, mesangial cell contracts and modulating GFR and RBF. I don't want to talk about this too much, but it's a little bit confusing because ETA causes contraction, but the ETB causes relaxation. So it's causes both So it's kind of confusing, but it's true that that's why ET could be just a balancer rather than just a contractor in mesangial cells. But mesangial cell express ET1 receptors, and then endothelin definitely has a function on mesangial cells. This is also proximal tubular cells have ET receptors. This is also conflicting results. It's still under investigation, so I just don't want to mention too much. But endothelin 1 binds to endothelin ETB receptor that causes inhibition of sodium potassium ATPase and also sodium proton exchanger. So by doing that, it causes inhibition of sodium reabsorption. Stay with me a couple more slides on this. So ET1 also actions in a thick ascending limb of loop. It can inhibit NKCC2. By the way, what was the inhibitor of NKCC2? What kind of drug is the NKCC2? Yes, loop diuretics can block NKCC2. So ET1 has the same actions on the thick ascending limb of loop. Okay. Okay. I got.
Sorry guys, we have to go out there and come check the rooms, so.
All right, thanks for coming back. I appreciate it. Okay, so endothelin 1 can inhibit NKCC2, which is the same actions as loop diuretics. Also, endothelin 1 can inhibit sodium channel, it's ENaC. Do you remember what was the ENaC inhibitor? Amiloride. Amiloride was ENaC inhibitor. So it's the same effect as potassium sparing diuretic, amiloride, and also inhibit ADH mediated aquaporin translocation. Do you remember what does this? The vasopressin receptor antagonist inhibits aquaporin translocation. So endothelin can work. Well, proximal to is a question mark, but at the loop, it blocks this. It's the same effect as loop diuretics. And at the correcting that, it inhibits ENaC, which is the same effect as amiloride, and then blocks aquaporin translocation, which is the same effect as vasopressin receptor antagonist. So it's a combination of good diuretic medications. So that's why you may think that ETB activation has a natriuresis and anti-hypertensive effect. And you may think that the ETB receptor agonist could be good. Could be good, but currently this is not available. So that's why I'm saying by the time you become a physician, maybe ETB agonist may be available as one types of diuretics. By the way, here you may want to know ETA receptor antagonist is available and then widely used for the treatment of pulmonary artery hypertension. I think even in a first aid textbook, it describes that. That's because, remember, the vasculature through the ETA receptor endothelin causes vasoconstriction. So antagonists of this receptor cause vasodilation, and then it's very effective for pulmonary artery hypertension. So from endothelin, maybe this is the one you may want to remember. Other thing is just for future. I want to skip that. Prostaglandins. I know you guys know a lot about prostaglandins from biochemistry. 3 major sites of synthesis in the kidney: the cortex, medullary interstitial cells, and then collecting ducts. But like endothelin, do not function as circulating hormone systemically. It's a local effect in the kidney. By the way, prostaglandin has a lot of effects entire body, but in the kidney, it's a local effect. This also, you guys know this, you guys learned this from biochemistry. Prostaglandins are synthesized from arachidonate by COX. That's an enzyme, and then become mature prostaglandin E2, prostaglandin I1, and the others. And each prostaglandin has its own receptors. As you know, prostaglandins are vasodilators, and especially when renal perfusion is threatened by dehydration or something, PGE2, PGI2 are produced and then play a major role to protect renal blood flow and GFR. if you look at the kidneys here, there are a lot of COX and then prostaglandins are expressed throughout the nephron. So that's why I'm saying that the prostaglandins could be very important to regulate GFR, especially cortical COX-2. Prostaglandins maintain renal function, which I'm going to show you in the next slide. And then medullary COX-2, there are two different functions. Cortex-1, cortical COX-2 regulates the renal function, GFR, but the medullary COX-2 causes sodium homeostasis, which I'm going to show you in a couple of slides next. One thing, this is good to remember. I showed you this. Macula densa sense that decreased level of sodium chloride, and in that case, macula densa produces COX-2, and that helps to produce prostaglandin E2 from macula densa, and then this is delivered to Jejunum cells because Jejunum cell has a receptor, and then that causes renin release. I talked about this, but that's how prostaglandin E2 can control kidney function. COX-2 at the cortex, as I said, increases renin. And medullary COX-2 actually enhance sodium secretion. So renin, increase the blood pressure, but the sodium excretion reduce blood pressure. So it's kind of two, opposite effects are regulated by COX-2. So that's why not many people talks about that. But this one you should know. COX-2 is a target of NSA. So that's why the NSA blocks COX-1 and then blocks the prostaglandin E2 production. As you know, prostaglandin E2 protects the stomach mucus. So blocking this causes ulcer. And I'm not going to talk about the heart, but in the kidney, if you block this, blocking prostaglandin E2 and prostaglandin I2 production, and then that actually maintains afferent artery vasodilation, and if it blocks that, it causes problems. Especially, I think you guys know this, and I think this one should be important for exam as well. In healthy individuals, the impact of prostaglandins on renal perfusion is limited. So, but in the setting of advanced age, dehydration, and kidney failure, prostaglandin synthesis is upregulated to preserve renal blood flow and protect the GFR by decreasing afferent artery resistance. So which means that if something goes wrong, dehydration or heart failure or something, the prostaglandin synthesis is increased, and then prostaglandins vasodilate afferent arteries to protect to secure the enough blood flow to the glomerulus. But if you give NSAIDs for the patient who are experiencing dehydration, then you block this, and then you artificially create kidney failure by NSAID. So that's why I'm saying that you have to be very careful to use NSAIDs for the patient who are dehydrated or aged or heart failure or kidney failure. All right, so bradykinins. Bradykinins, you have heard of it, right? Because of one reason. I know when you guys always talked about ACE inhibitors, and I'm going to talk about this later. I'm going to talk about this later. So bradykinins are very similar to those of prostaglandins, which means that they can vasodilate the kidney, and also can be natriuretic. So here is a picture that I showed you before. This is endothelial cells. This is smooth muscle cells. ACE angiotensin converting enzyme is located in the endothelial cell. So when angiotensin 1 comes in, this converts to angiotensin 2, and that causes vasoconstriction. Endothelin, as I said, can cause vasoconstriction. Prostaglandins can be produced from endothelial cells and then cause vasodilation. Bradykinin is actually directly work on endothelial cells, and then the Treg cells produce nitric oxide that causes vasodilation. It says that has a natriuretic, but the mechanism is unclear. So this slide, you don't have to remember this, but what I want to show you is that this is how bradykinin is produced. It is produced from kininogen, and a kallikrein, this enzyme converts to the bradykinin, and the bradykinin is degraded into inactive fragments by the enzyme called kininases. The reason why I want to say that is that angiotensin converting enzyme is one of these, the same effect. So angiotensin ACE does this reaction. So that's why if you give ACE inhibitor, you are blocking this side. Then bradykinin is more accumulated, right? If you use the ACE inhibitor, you are creating a lot of bradykinin. Bradykinin does something on the kidney, yes. If you look at this, for example, this is kinin receptor. Kinin means that kallikrein receptor, kinin receptor, bradykinin receptors are everywhere on cortex and medulla collecting duct, and then other the bradykinin related molecules also expressed everywhere in the kidney. And bradykinin actually can inhibit sodium reabsorption in the collecting duct, causing natriuresis. But that's not important. I wouldn't say important, but that's not something I wanted to show you. I wanted to show you the only slide I said important from today's lecture is this. You guys all know ACE inhibitor causes dry cough, right? That's the side effects everybody knows, but not many people know why. And you know that that's because of bradykinin, but why bradykinin causes cough? So that's why I wanted to show you this. Remember ACE, angiotensin converting enzyme, is in where? Yeah, lung, endothelial cell in lungs, in the kidney. Actually, everywhere in the body, but the lungs and then kidney. So that's why if you block angiotensin converting enzyme, the effect comes into the lung, and then bradykinin is accumulated in the lung, and then that leads to the activation of pro-inflammatory peptides and the local release of histamine, which irritates lung cells. That's the mechanism how ACE inhibitor causes dry cough. The other side effects that you will see on the exam is angioedema, which you might know that, but you haven't seen. It looks like this. I got the picture. Right? Even though ACE is localized in the lung, but angioedema happens everywhere, including those everywhere. If it happens in GI, it creates diarrhea, and it happens on the face, you will see, you may not notice, but the lip is swollen here. So you can tell from the patient's face. If you see like this, then you know you are giving ACE inhibitor, and you have to be careful that. So this is the only slide I want you to remember from today's lecture. Natriuretic peptides. Let's go over real quick. You guys know ANP, BNP thing? Okay, so good. So ANP is atrial myocyte produced, and BNP, ventricular myocyte produced, but the kidney produce a related natriuretic peptide. It's called urotiratin. It's a ANP analog. Once again, ANP is stimulated by atrial wall stretch, and BNP is stimulated by ventricular stretch. The only thing I want to mention, which you may know, is that BNP is produced when the heart is stretched, means that in heart failure patients, ANP production goes up. So this ANP or inactive precursor NT-proBNP can be a biomarker for the heart failure patients. So in heart failure patients, the cardiologist often measure NT-proBNP, and if this level is shows really high, which means that the heart failure control is not good. All right, so volume expansion causes production of ANP and BNP. Those are actually vasodilators, so it can dilate vessel. It knows it inhibits aldosterone, and it inhibits renin secretion, and it inhibits sodium reabsorption. So this is almost like angiotensin aldosterone system inhibitors. So ANP, BNP has receptors, especially, I'm not going to go too much detail, but the ANPRA is highly expressed in the kidney. This is NPRA, so this is a receptor for ANP and BNP in the kidney. You don't have to remember anything else, but if ANP, BNP binds here, all the way coming back, it produces cyclic GMP. The reason why I emphasize that is that, okay, the heart produces ANP and BNP, and this is the kidney cells, and then binds here, and it causes cyclic GMP. And cyclic GMP reacts with smooth muscle cell tissues, leads to vasodilation. Because of that, ANP has an effect to dilate afferent artery so that the GFR is increased. And effects of ANP on efferent artery is controversial. Some people say vasoconstriction. I don't know the mechanism much, but some say it's about dilation, so you don't have to worry. It's still under investigation, so you don't have to remember anything. But the ANP vasodilates afferent artery and then increase GFP. Also, cyclic GMP in tubular cells knows that to inhibit ENaC, by the way, ENaC inhibitor is amiloride, and inhibit sodium-potassium channel. That way, sodium cannot be absorbed and then sodium comes out to the urine, causes natriuresis. That's why it inhibits sodium reabsorption. So it's all good thing because the four actions of ANP, BNP, vasodilatation, particularly by afferent artery, leading to the increased GFR, good. And the inhibition of sodium chloride reabsorption by collecting ducts, causing more urine. So it's good for hypertension. And then inhibition of renin secretion from JG cells by cyclo-GMP dependent process, good. Inhibition of aldosterone secretion by adrenal cortex, good. So overall, it antagonizes the effect by RAA system. Then, first thing you should do that, why not use this for therapy? Actually, it's being used. This is a small peptide, so it's very easy to make in the lab using E. coli and recombinant peptide NP, BNP are produced and have been used for heart failure patients last 2 decades actually. But the reason why it's not emphasized much is that the opinion varies because for short term, it's very helpful to improve the symptom in heart failure patients, but for the long term, it doesn't really change the mortality and morbidity. So now it's not really first line of choice to use, but I just want to say that newly synthesized homologue of this molecule, also inhibitors of enzyme that metabolize ANP, BNP are currently being investigated. So once again, by the time you become efficient, maybe this drug may be available. All right, so I know today's lecture was not really informative for your exam, but we cover those other molecules which may be important for the future medicine. Is that okay? All right. What should we do? Keep going or?
Keep going.
Keep going. Okay, let's keep going and finish early. The next topic is myocardial infarction and its effects on the kidney. As the heart grows, so go the kidneys. That's true. The heart is responsible for ensuring that blood is circulated. You know that. And the kidneys are responsible for filtering the circulating blood. Renal and cardiac dysfunction often coexist. About 30% patients with heart failure actually have CKD, chronic kidney disease. This is because they share the common risk factors as hypertension, diabetes, hypercholesterolemia, smoking, less exercise, all share the common risk factors. So 30%, they come together. So if you find heart failure patients, you have to worry about kidney function. If you find chronic kidney disease patients, you have to worry about the heart function too. All right, case. Can anyone read this history, please? Please, thank you.
A 70-year-old man has been well until 3 days earlier when chest pain developed and he was accompanied by mild dyspnea. He was taken to a hospital within 30 minutes where a lab study showed that BUN was 47 milligrams per deciliter and the creatinine was 2.4. EKG revealed an evolving MI. During the exam, 2 bouts of non-sustained ventricular tachycardia occurred. Nitroglycerin, aspirin, and lidocaine were administered. The patient was immediately sent to cath lab for further evaluation of CAD.
Thank you. So, this is a real case from Massachusetts General Hospital, 80%. 20% I made up. So I just want to mention that. The history is true. Some lab results are not true, I just made up. So nitroglycerin, what is that for? Yes. Aspirin?
Like clots.
Yes.
It's like pain.
Pain?
I'm kidding. What she said.
Yes. Pain, yes, true. But in this situation, no. This is for VT. All right. So cath lab, this is not cardiac module, so I'm not gonna go to the detail, but this is coronary angiogram, which you puncture either femoral artery or radial artery, and put the catheter in here, and all the way to the heart, and then contrast reagent can be injected through the cath, and you check the X-ray, and then you can visualize coronary arteries. So this is left LAD, left ascending artery, and here before angioplasty, you can now see this artery here. So it's a 90%, 99% stenosis. So the cardiologist put the stent in here, and now the blood flow is secured. So that's PCI, percutaneous coronary intervention with bare metal stents. There are two different stents, bare metal and drug-eluted stents. It's a big discussion which is better, which is not good. It's all the way last a decade. They're talking about it. But in this case, bare metal stent was used. So now it's good. The heart is good. And the chest pain subsided and the EKG changes resolved. On the fourth day, the patient was transferred to your hospital. So it's, PCI, you have to do that in a big hospital. So ambulance bring the patient to the big hospital. Now came to you. Let's say you are working in a smaller hospital. So the patient remained free of cardiac symptoms after the transfer, which is good. Let's see the past history. There was a 10-year history of hypertension. Heart problem, of course, that's a risk factor. But it was controlled by thiazide. As I said, thiazide is the first line of choice to treat hypertension. That's why patient was taking thiazide. He had smoked one pack cigarette, but discontinued. Family history, his father had MI too. Okay, so he's at risk. Vital sign, blood pressure is normal, and then nothing stands out, so it's good. So now his condition is stable. Head, neck, normal, lung clear, heart sounds normal, no edema. Okay, that's good. Let's see the lab test. Hematocrit, well, a little bit low, but it's okay. White blood cell, that's okay. Platelets, okay. So hematologic values are all fine. Urine test. The urine was normal except for a trace positive test for protein. No oliguria or no polyuria was observed. No active sediments such as red blood cells. That's good, but because proteinuria is observed, let's check albumin to creatinine ratio, which was 229 milligrams per gram. I'm not sure you remember normal value, but that was normal is less than 30, and then between 30 and 300 milligram per gram, it's called microalbuminemia, and over 300, it's called macroalbuminemia. So he has microalbuminemia. Okay, so chemical BUN high, and it's still high, and creatinine is high and still high. Actually, in fact, on admission to your hospital, 3 days after MI, the creatinine levels have increased from 2.4 to 3.0. So it's getting a little bit worse. And in BUN also increased from 47 to 56. So the kidney function is getting worse, even though heart function now it's better and it's stable. What else? Sodium is a little bit low, but it's fine. Potassium is fine. Cholesterol, nothing stands out. Glucose is 119. Okay, so nothing really stands out. All right. So because he had a kidney problem, you perform ultrasound in the kidney. Before I showed you this patient's kidney renal ultrasound images, let me quickly overview how you evaluate the kidney ultrasound. So this is actually normal image. Of course, ultrasound is commonly used, and you can measure the length from here to here, like from here to here. That the normal length is 10 centimeter, 12 centimeter, even though the right kidney is often slightly longer than left kidney. Also, often they measure the length here and here. That's a cortex, cortical thickness, and then this is parenchymal thickness. This information is helpful because if CKD, chronic kidney disease goes, this thickness is getting thinner and thinner because kidney cells are basically dying. And then the thickness also thinner and thinner, and the length also is thinner and thinner. So routinely, the technician to perform this measure those lengths. By the way, here, this is cortex. We see like this, and the pelvis here. One thing you can pay attention is hydronephrosis. It's not really relevant to this topic, but ultrasound is very useful to diagnose hydronephrosis because let's say the kidney stone stuck on his here, and then urine keep producing, and then piling up inside the pelvis, and then compress the other side of tissues. So that's called hydronephrosis. The reason why you see it here, it's a lot of black area. That's urine. That's this part. So it's very easy to diagnose if hydronephrosis is here or not. The reason I'm going to show you why this is important. Ultrasound is very useful to diagnose that. Okay, let's see this patient's ultrasound. This is a real ultrasound from this patient who are in Massachusetts General Hospital in about 15, 16 years ago. So this patient, so this is right kidney and this is left kidney. If you look at that, and then they measure the length, which is 7 centimeter long in left. Right kidney has 6 centimeter, and then left kidney has 7 centimeter. And cortex, not much cortex left. So both sides are atrophied, which suggests more like a chronic kidney disease. Also, they perform echocardiography. The point is that they found that the segmental dysfunction, because it's MI, but the overall function was normal. It's ejection fraction. Do you know ejection fraction? Kind of, sort of. That's a, normally it's a systolic cardiac function is evaluated by ejection fraction. It's a normal value is 55 to 70%. This patient was 60, which means 60 systolic function should be normal. Although these days there are a lot of different types of heart failure. If even systolic function is okay, sometimes they are categorized as heart failure. So it's complicated, but don't forget about this. Just ejection fraction was normal. So suggests that probably cardiac output should be normal. All right, so what I want to discuss from this case is that this is a group classification of not chronic, but acute renal failure. You have to determine it is pre-renal renal failure or intrinsic renal failure or post-renal renal failure. In this case, we know this is not true because if that's the case, we should see hydronephrosis. That's why we perform the ultrasound. So most likely not this. And we see if that's a pre or intrinsic. And then moreover, we see this is even acute. So then, you have to think of all the timeline, time of onset. Because renal hypoperfusion, liminal hypoperfusion I'm talking about here, pre-renal. Because this is the MI patient, first thing you have to think of is that maybe because of heart failure, MI, renal perfusion is not enough, that causes kidney failure. That's the first thing you can think of. But renal hypoperfusion is a frequent cause of pre-renal acute renal failure. But this patient history and physical exam revealed no overt cause of pre-renal azotemia, such as dehydration or congestive heart failure. Remember, ejection fraction was normal. So despite the recent MI, he had a normal ejection fraction and a finding against hypoperfusion due to a reduced cardiac output. So most likely, hypoperfusion, renal hypoperfusion cannot explain kidney failure. And then now you have to think of other possibility. Hypotension, no, this patient had a good blood pressure, so no. ACE inhibitors, like I always say, ACE inhibitors decrease GFR. So if patient was taking ACE inhibitor for hypertension, then ACE inhibitor may be the reason causing lower GFR. But in this case, no. NSAIDs, as I said, has a strong nephrotoxic effects for the patient who has dehydration and heart failure. But he was not taking NSAIDs, so this is no. Aminoglucoside antibiotics, I talked about this once. It has effects in mesangial cells. That's one thing. Also, aminoglucoside has nephrotoxicity for the tubular cells. So it causes acute tubular necrosis. So it's a well-known adverse effects of aminoglucoside is kidney failure. But in this patient, no. And then finally, a radio contrast agent, because he was performed PCI, which, radio contrast agent will be used. that's also well-known thing that causes nephrotoxicity. Yes, because he was performed PCI, but the plasma creatinine began to rise before PCI, so most likely radio contrast agent was not the reason. It's okay, everything. It's okay? All right, so most likely a renal ultrasound show bilateral cortex atrophy and a no-hydronephrosis, and suggests that this is a pre-existing chronic kidney disease, and exclude the possibility of post-renal disorder because there's no hydronephrosis. Also, proteinuria and a 10-year history of hypertension support a possible diagnosis as nephrosclerosis. I'm going to talk about nephrosclerosis in the next slide, but other possibility is microangiopathy. I'm not sure you have covered this already in the pathology class or not, but for example, well-known one is vaginal granulomatosis with polyangiitis. That's a more recent name. This is old name. But this is like an immune disease. It causes a lot of vasculitis all over the body, but including the kidney. That could be possible for diagnosis, but this causes hematuria often, and then we didn't see that, so most likely this is not the case. But overall, most likely diagnosis for these patients is nephrosclerosis. Nephrosclerosis, sometimes called hypertensive arterial nephrosclerosis, is a progressive kidney disease caused by long-standing, poorly controlled high blood pressure. So this is a slide. This is not the glomerulus. This is a slide of arteries. So arteries is very narrow because of hypertensive change of hyalinosis, and so that can cause ischemia in like here. So this is like a cross section here. So hyalinosis is happening here. So narrowing afferent artery. It looks like this. And because of that, it causes a lot of problems. Let's say collagen accumulation causes fibrosis, and then it damages the entire glomerulus. So that's why nephrosclerosis is one of the most common end-stage renal disease. The reason why I showed you this is because, once again, comes to the research paper, that distribution of GFR among 20,000 patients with acute MI. If you look at that, MI patients, a lot of them have really low GFR because coexistence of kidney disease and MI. There's a message from me for you from this. This is just showing that the GFR is associated with increased mortality rate in patients with acute MI. For example, here, if GFR is low, probability of cardiovascular event is low, but the GFR is high. If GFR is low, then higher chance to develop a coronary artery disease. The reason why I want to show you this is that so if you're a mediocre doctor, you only care about past history and the present history, and then you think of what kind of medicine is good. But if you're a better doctor, you always care about the future of the patient. To know that, which is prognosis, to know that, you have to know kind of evidence-based medicine and how you can foresee the patient's future. GFR is helpful because if you calculate GFR, you know the future. This patient, for example, in 24 months, 2 years from now, about 40% of chance or 50% of chance he will develop MI. So, PBL, I always say PBL, no information is provided for you to calculate GFR, right? That's our fault, our side of fault. But no students wanna ask us, I wanna calculate GFR because I wanna know the future of these patients. No one says something like that. That's my kind of suggestion. If you wanna know the future of the patient, you have to calculate GFR because GFR shows you the prognosis of the patient. Another thing, this is the same thing. If GFR is slow, not just only cardiovascular disease, not just heart disease, it causes a lot of problems. Reinfarction, death from cardiovascular causes, all high if you have low GFR. Another thing is that microalbuminemia or albuminemia, it's not just only one dimension. Even though the GFR is high, if patients have microalbuminemia, it's a higher chance to develop cardiovascular disease. In this case, it's only type 2 diabetes. So the reason, because of those facts, International Society Nephrology recommends this. Let me show you, explain this. This is a kind of algorithm using 2 dimensions. The first dimension is GFR. GFR is high to low. And then second dimension is albumin creatinine ratio. Less than 3, which is normal. 32, 300 is microalbuminemia. Over 300 is macroalbuminemia. So let's say no albuminemia. Then if GFR gets low, it shows a red. Red means very high risk. And if, let's say, GFR is normal, but if the patient has high macroalbuminemia, shows this, orange, this is high risk. It means that even if the GFR level is the same, if your patient has higher level of albuminemia, the prognosis would be poor. Okay, let's do some practice. Can you evaluate this patient's prognosis? I just listed his data. He is 70-year-old male. His creatinine level was 3.0. His serum BUN was 56. Urine volume was 2 ml per milliliter. Urine creatinine level is 60. Urine albumin to creatinine ratio was 229. You can calculate GFR, but this is normalized by body surface area. So for now, you can use 1.73. So you can measure GFR and then divide it by 1.73. And or, if you're lazy and if you're online, you can click here and then calculator comes up and then you can type in and then you get the results. But maybe you can do it at home. But for now, can someone measure, calculate GFR? By the way, I don't remember. So someone has to tell us.
In the online calculator, it just says creatinine. Is that the?
Yeah, so that's EGFR that I mentioned that a couple weeks ago. That's just it's called EGFR. It's just a simple version prediction, so it's not real GFR. But to calculate EGFR, you only need age and race and gender and serum creatinine. That's estimate. It's called estimated GFR. You can use that in a hospital. Most likely they use eGFR instead of real GFR. But because this is a practice, I want you to calculate real GFR. Yeah. If you don't remember that equation, GFR has to be urine creatinine levels times urine volume divided by plasma creatinine. Yes.
And that's it?
That's it, but for this, it says divided by body surface area. So you can you just divide it by 1.73 for now? Because we don't know the body surface area for the patient. 23, yes, sounds like it. Everyone knows how to do it? Just urine creatinine level times urine volume divided by plasma creatinine level. And then, most often in hospital, you normalize by body surface area because everybody has a different body size. And in this case, 1.73. Most easily, like I say, EGFR, people use that in the hospital a lot. Just simple calculator is available, and then, that's just estimated, not the actual GFR. So calculating GFR by yourself is more accurate. So let's say it's now 22, which is here, right? G4, category G4. And his albumin level was 229, which is A2. So A2 and G4 means red. And you may not be able to see it, but is it 3 or 4? 3. 3 means that International Society of Nephrology suggests that you have to at least see your patient 3 times a year because he's at high risk. If it's more than 4, it's worse function. It says over 4, meaning that you have to see patients, you have to ask the patient to come back. 4 means every 3 months, more often, more frequent than every 3 months. So that's, how you have to treat patient. That's why my message here is that GFR is important because GFR can tell you the prognosis based on evidence-based medicine. Serum creatinine level itself tells you, okay, kidney function is not good. but that doesn't tell you the prognosis. Everyone is okay with this? GFR? GFR, calculation of GFR might be asked on the exam. Not in this thing, but calculating GFR might be asked on the exam. Okay, all right. Once again, I start talking something not important. But the existence of dual dysfunction has been recently termed as cardiorenal syndrome. You cannot find this name on the first aid textbooks. But in real medicine world, the people call this cardiorenal syndrome because that's a bidirectional relationship between kidneys and the heart. And they classified cardiorenal syndrome. No need to remember this, just for the future. We have 5 different types. Type 1 is acute cardiorenal, means that the heart dysfunction causes kidney dysfunction. That's why acute cardiorenal. Type 2 is chronic cardiorenal, means that the chronically heart dysfunction causes the kidney dysfunction. Type 3 is acute renal cardiac syndrome, means that the acute kidney failure causes acute cardiac failure. Type 4 is chronic renal cardiac, means that the chronic kidney disease causes chronic heart disease. And the last 3, it's just a simple, more systemic disease like SLE or, other system amyloidosis, for example, sepsis, those are, affect both organs. So that's called type 5. Just look over this quickly. Because 2 organs are involved, of course, multiple mechanisms have been implicated. Not that just simple. One disease causes, one mechanism causes one disease. It's not like that. But, the sympathetic nervous hyperactivity could be one reason. And, it's normally compensatory mechanism in the heart failure happens. And that causes sympathetic nervous hyperactivity. If you remember, sympathetic nerves regulate kidney blood flow, right? So it causes hyperactivity, and it causes, blocking renal blood flow. That causes kidney dysfunction too. Another reason is that because of heart failure, blood flow perfusion should not be enough to supply kidney. But that is actually, it's called classical view. More recent theory, it's called venous congestion. It's too much detail, so I don't want to go over it, but it's in view of current clinical medicine evidence, increased renal venous pressure causes reduced renal perfusion pressure because blood flow through the kidneys depends on the pressure gradient between the artery and venous side, which means that, so this is a classic view. Classic view is that because of heart failure, decreased renal blood flow, and then kidney injury. But the more recently, it is called that because of heart failure, it causes hypervolemia and increases systemic and pulmonary congestion, and then causes renal venous congestion. So there are 2 different mechanisms are proposed. Type 3 kidney failure causes heart failure. That's because, once again, it's the same thing. Hypervolemia causes increased pulmonary congestion and then causes heart failure. Which means that the goal of the therapy is to correct hypervolemia by aggressive diuretics What kind of diuretics would be good? Yeah. So in acute phase, loop is the strongest, fastest. And like I said, the patient with chronic kidney disease, diuretics don't work. But loop is the only hope, the only choice that it works really good. If you want to treat acute phase, loop. If you want to treat more chronic phase, thiazide will be good. Just finally, one quickly just to cover more chronic type, chronic cardiorenal syndrome. So long-term cardiac dysfunction causes kidney. The mechanism is proposed RAS system is overemphasized in many ways, but here also activation of RAS can cause a bunch of effects. Or some people say that the inflammatory cytokines is activated. Also, we learned today endothelin-1. The mechanism is that endothelin-1 causes progression of glomerulosclerosis because that causes vasoconstriction in the kidney. Anyway, you don't have to read those, just a figure that the heart causes kidney dysfunction over and over, and then causes progression of chronic kidney disease. All right, with that, it's just that's it for today's lecture. Just one message that the concept represents conference of the heart-kidney interactions across several interfaces, and then characterization of this complex syndrome is hoped to contribute advancement of future medicine, which you will be responsible. I apologize that I talked about something not for exam, but sometimes it's good to review all clinical current medicine. If you have any questions, just let me know. Is that okay?